Welcome to ClinMed Compass. I am Dr. Emoriken, your host. Today, we'll be looking at hyperkalemia, key clinical facts. Let us break down these essential points you need to know about this potentially life-threatening condition, hyperkalemia. By the end of this lecture, you should be able to define hyperkalemia and understand the normal serum potassium levels, identify common causes, recognize clinical and ECG features of hyperkalemia, outline diagnostic steps, and summarize the key principles of treatment of hyperkalemia. The normal potassium levels is from 3.5 to 5.5 millimoles per liter. However, it is important to state that this range varies across laboratory. Hyperkalemia is therefore defined as the serum potassium levels greater than 5.5 millimoles per liter. Severity of hyperkalemia varies. We have mild, moderate, and severe hyperkalemia. The mild hyperkalemia from 5.5 to 5.9 millimoles per liter. Moderate from 6 to 6.4 millimoles per liter. And greater or equal to 6.5 millimoles per liter, it's severe hyperkalemia. Severe cases, that's potassium level above 6.5 millimoles per liter, can cause life-threatening cardiac arrhythmias like ventricular fibrillation or cardiac arrests. A quick review on the pathophysiology of potassium. 98% of the body's potassium is intracellular, while only 2% is extracellular. The sodium-potassium ATPase pump maintains this gradient, pumping potassium in and sodium out. This balance is essential for the resting membrane potential, action potential generation, proper nerve, muscle, and heart function. The kidneys play a central role, excreting about 90% of daily potassium. Aldosterone promotes potassium secretion in the distal nephron. Other regulators include insulin and catecholamines, which drive potassium into the cell. In acidosis, potassium moves out of the cell, and alkalosis, potassium moves into the cell. It is very important to recognize this key regulatory mechanism of potassium. Causes of hyperkalemia. Hyperkalemia could be true hyperkalemia or the pseudo-hyperkalemia. We'll start with the true hyperkalemia. True hyperkalemia can result from reduced potassium excretion, which could be from acute kidney injury or chronic kidney injury. It could also arise from impaired tubular secretion of potassium, which could arise from aldosterone deficiency, from Addison's disease, drugs like ACE inhibitors or the ARBs, NSAIDs, and heparin. We also have hyporeninemic hypoaldosteronism, which is found in patients with diabetic nephropathy. Other causes include potassium-sparing diuretics like spironolactone, tubulointerstitial nephritis from various causes like lupus nephritis post-transplant, inherited tubular disorders which give rise to pseudo-hypoaldosteronism. It is important to state that these conditions often present as type 4 renal tubular acidosis, which is usually characterized by metabolic acidosis and hyperkalemia. So we'll look at the causes of hyperkalemia, which can result from transcellular shift from the intracellular fluid to the extracellular fluid. Potassium may shift from inside the cell to outside the cell, and these conditions could make that happen. Metabolic acidosis, diabetes ketoacidosis, or even drugs like beta blockers. Conditions that result in reduced catecholamine or aldosterone. Tissue breakdown, as in rhabdomyolysis, Pons, tumor lysis syndrome. Genetic channelopathies like the hyperkalemic periodic paralysis or the Gordon syndrome. Some drugs can also result in such shifts. Suxametonium, a depolarizing agent that causes potassium efflux from muscles. Then beta blockers actually inhibit beta-mediated potassium uptake. Let us take a look at the causes of hyperkalemia from increased potassium intake or administration. Excess potassium intake is rarely a sole cause of hyperkalemia unless renal excretion is impaired. However, we should be cautious with overzealous oral or parenteral potassium supplementation, massive blood transfusion, as well as salt substitutes high in potassium. Pseudo-hyperkalemia or artifactual hyperkalemia. Not all high potassium values are read. Pseudo-hyperkalemia can result from hemolysis during venipuncture, EDTA contamination from the wrong sample tube, leukocytosis or thrombocytosis, delayed sample processing, especially in primary care. If pseudo-hyperkalemia is suspected, repeat the sample urgently. This slide summarizes all major causes of hyperkalemia grouped by mechanism: decreased renal excretion, cellular shift, and excessive intake. It's important to keep this as a reference during clinical evaluation of hyperkalemia. In mild cases of hyperkalemia, the patient is often asymptomatic. However, symptoms of hyperkalemia include muscle cramps or weakness, flaccid paralysis, paresthesia, palpitation, and in severe cases, we may have arrhythmias, ventricular tachycardia, or ventricular fibrillation, and sudden cardiac arrest. Classic ECG findings in hyperkalemia include peaked T waves, which occur as one of the earliest signs of hyperkalemia, prolonged PRO interval, flattened or absent P waves, widening QRS complexes, and in late stages, sine wave pattern or ventricular tachycardia fibrillation, which eventually leads to asystole if untreated. ECG changes may not correlate well with severity, so it's important to monitor closely. We will now take a look at the ECG changes based on severity of hyperkalemia. In mild hyperkalemia, we found the tall peaked T wave, basically in the precordial leads from V2 to V4. The ECG tracing shows the tall peaked T wave, as you can see. Then the moderate hyperkalemia, we expect more prominent peaked T wave, widening QRX complexes, prolonged PRO interval, or the absence of flattening P wave. The early signs of atrioventricular conduction delay begins to show at this stage of moderate hyperkalemia. This is the tracing showing you the flattened P wave as well as the widened QRX complex. At potassium levels above 6.5 millimoles per liter, which is a severe hyperkalemia, the ECG may show the sine wave pattern, which results from fusion of the QRX complexes and the T wave. Ventricular arrhythmias like ventricular tachycardia or ventricular fibrillation may follow, and asystole if untreated. This ECG tracing shows the sine wave pattern. This slide visually summarizes the progression of ECG changes in hyperkalemia. This is a normal ECG finding, the P wave, QRX complex, and the T wave. So we have the tall tented T wave here, as you see in this arrow, the flattened P wave, we may progress to the widening QRX complex and a sine wave pattern eventually. This is a summary of the presentation of hyperkalemia and corresponding ECG changes as a result of severity. The mild hyperkalemia, the moderate hyperkalemia, and the severe, and their respective symptoms and ECG changes. Use this to correlate potassium levels with ECG findings during clinical evaluation. As part of the diagnostic approach, you must confirm true hyperkalemia. If you suspect pseudo-hyperkalemia, it's important you repeat the sample collection. You review medications, especially those that can cause hyperkalemia. You do your ECG even if the patient is asymptomatic. You assess renal function tests, blood glucose, arterial blood gases to assess the acid-base status. You may do urinary potassium, especially in unclear cases. You have to run a drug screen and do an adrenal test, cortisol, ACTH, if Addison's disease is suspected. Look for hyponatremia. This may suggest aldosterone deficiency and metabolic acidosis, especially if type 4 renal tubular acidosis is suspected. Let's take a look at the treatment of hyperkalemia. If potassium levels are above 6.5 millimoles per liter, you start emergency treatment immediately. We follow a 3-step approach in this emergency treatment. The first thing to do is to stabilize the cardiac membrane by giving IV 10% calcium gluconate, 10 ml over 2 to 5 minutes. Alternatively, calcium chloride can be used. The second thing to do is to shift potassium into the cells. IV insulin plus glucose, or 10 international units of regular insulin plus 50 ml or 50% dextrose water. Nebulized beta agonists like salbutamol can be used also to cause such shifts. Then sodium bicarbonate used only if acidosis is present. Step 3 is eliminating potassium from the body, which can be achieved through dialysis, either hemofiltration or hemodialysis. Dialysis is definitive, especially in cases of renal failure. Dialysis is indicated in severe or refractory hyperkalemia. Use ion exchange resins like the sodium polystyrene sulfonate resin, the K-oxalate, and the calcium polystyrene sulfonate resin, calcium resonium. These bind potassium in the gut and prevent their absorption. They can be given via the oral or the rectal routes. Newer agents like the pathophysiology and the sodium zirconium can also be used. Loop diuretics can be added if there is fluid overload and the renal function is intact. This table summarizes the key emergency treatments for quick reference in clinical settings. Step 1 is stabilizing the myocardium or the cardiac membrane by giving IV calcium gluconate or chloride. Step 2, shift potassium intracellularly, giving IV insulin plus glucose or nebulized salbutamol. And step 3 is to eliminate potassium from the body by using dialysis, use of ion exchange resins also. In mild cases, do the following. Identify and treat the cause of hyperkalemia. Stop potassium-rich foods and supplements. Review and discontinue potassium-containing drugs like the ARBs or the ACE inhibitors, NSAIDs, and potassium-sparing diuretics. Use oral potassium binders, the calcium resonium or the K-oxalate, and add loop diuretics if there is fluid overload. To wrap up this topic, take note of the following. Hyperkalemia is a medical emergency that can lead to life-threatening arrhythmias and sudden cardiac death. Most common causes include renal failure and renin-angiotensin aldosterone system blocking drugs like the ACE inhibitors and the ARBs. Look for ECG changes of hyperkalemia like the peak T waves, the widened QRS complexes, or flattened P waves that may even progress to sine wave pattern. Follow a stepwise approach in the management of severe hyperkalemia. Stabilize the cardiac membrane, shift potassium into the cell, and eliminate potassium from the body. Calcium gluconate and insulin glucose are first-line emergency treatment of hyperkalemia. Always manage the underlying causes, not just the potassium level. Dialysis is definitive for refractory or severe hyperkalemia. Thank you for joining me for this lecture on hyperkalemia. I trust your understanding of this critical topic has been greatly enhanced. Always keep in mind the emergency management steps for severe hyperkalemia. Stabilize the cardiac membrane, shift potassium into the cells, and eliminate potassium from the body. If you found this video helpful, please like, share, and subscribe to the channel for more engaging and insightful clinical lectures. Until next time, stay sharp and stay safe. Goodbye.